I'm very pleased to be here. I'm delighted that Karen has asked me to come along, and Mara Stillen had flagged this as a meeting that was coming up, and I did not need any arm twisting to be here. I think actually meeting people, joining the meeting and seeing people around the room, and talking to Rebecca a little bit earlier on, who's going to elevate the content of the meeting when I stop talking. It really shows what the energy is in the room. I think I was very impressed by the standard of the posters that came out remotely or electronically yesterday, and it's nice to see them in the flesh. And I do hope that this meeting will be a stepping stone to some interdisciplinary, inter-organisational / national joined-up thinking about where we go with palliative care rehabilitation or rehabilitative palliative care. As long as you use the word care, I'm going to be in your corner. So apologies to some of you who have seen some of my presentations before. If you've never heard of the policy for adult palliative care, you'll be hearing a little bit about it today. But in terms of my starting points, those of us of a certain vintage who remember when RTE television finished about 11 or 12 at night, Aran Navian, the Irish national anthem played, but the sun was set over this image. This is Inishtuishkert, which is the most northern island of the Blaskets off West Kerry. That's not my rib, and I didn't take the photo. But for some reason, even as a young fella, obviously my grandparents were aging and some died, but long before they died, I was aware of the fact that none of us lives forever. And I think this picture is always one that gives me a sort of a sounding board for what it is we do. Allied to the wisdom of Charlie Brown, but particularly Snoopy. So Charlie here says we only live once, Snoopy, but I think Snoopy might be a health and social care professional. Because he says, look, we live every day. We die once. Our role in specialist palliative care, what I say to patients when I meet them, often when they're nervous, not as nervous as Karen, but nervous of meeting palliative care, nervous of my mentoring the hospice, and so on. Our role is to find out what that person needs, what they want, and how we can best deliver it. And I think in terms of rehabilitation, rehabilitative palliative care, re-enablement, both physically and as one of the posters below from Our Lady's Hospice speaks to psychologically, we have a role to take on. And I think it's a role that we need to roll our sleeves up on. And as I said, we need to have some rather than intradisciplinary thinking about it. So, some more context. In Ireland, palliative care provision is based on need, not diagnosis, where you are, where the care is, or how young or old you are. And the national policy provides care to children, young adults, and the oldest of the old. In Ireland, we have 3 levels of palliative care provision. With the palliative care approach, which I think is a healthcare professional being a decent person, a decent human, and caring and supporting and putting the patient at the centre of what they do. And then general palliative care is what lots of people do, sometimes without knowing it, but in fact we need to help them do it better. People look after older patients, people look after patients with disability, people who look after patients with advanced heart disease, lung disease, neurological disease, and malignancy. And nationally, our services are delivered across joined-up services between acute hospital services, community specialist palliative care, and inpatient units, so specialist palliative care inpatient units. A colleague of mine used to refer to specialist palliative care being a service without walls, and we need to live that, and within that, our disciplines need to do the same. We know that in a short number of years' time, by 2028, there'll be more people living in Ireland who are over 65 than under the age of 14. That's a very significant shift, and whatever about birth rate and family size in terms of that sociological change, it does mean we're going to have a lot of older people to look after. And Peter May and Karen Ryan's and Charles Norman's work shows us that by 2046, there'll be 50% more people dying with a palliative care need. But really what's most important, going back to Snoopy in an earlier slide, is that 11 times that number, almost 500,000 will be living with a palliative care need. Not all specialists need. Most of it will be delivered by specialists in other areas providing general palliative care, but that need exists. And for the first time in Ireland, we asked on a national level what patients and their relatives who survived them when they died thought of the care that was being provided. And in the last 2 days of life, people are generally supportive of the care and happy with the care. And you might say, even in the acute hospital setting, where some of the pressures are greatest. But in the last 3 months of life, where we have a bit of time to plan, we've a bit of time to organise, we've a bit of time to discuss patients' care, the numbers fall off, other than in the specialist palliative care hospice setting. And particularly those of you who work in the hospital setting or who work in roles that cross into the hospital setting, we have a challenge to meet that. And in terms of the coordination of care, almost a quarter of people felt that there was poor coordination of care. Now, in another talk previously, I talked about palliative care staff having repetitive strain injuries, sort of wrists and shoulders, from patting ourselves on the back a little bit. We kind of talk about ourselves as being coordinators of care, and we often do that, but we are not the only ones. And I think other services need to benefit from our input, but maybe at their initiation rather than ours. And we need to make sure that what we do well, we continue to do well and do even better. So, this isn't really a history lesson, but 2001 is a while ago at this stage. First national palliative care policy endorsed by government, I think probably internationally, was published. The model of care came out in 2017, I think, and this is a living document that my friend and colleague, Professor Karen Ryan, led on when she was in the clinical lead role. And then the government woke up to care needing to be provided to everybody. So they wanted universal person-centred care in Ireland. And I think that's a lofty aim. And the aforementioned policy, published at last, launched in Dublin in September of 2024, kind of sets out the roadmap for us to follow those aims of Sláinte care. So there's one goal, the delivery of universal palliative care. There are 3 principles: that people would have access whenever they needed it, and they would have access to services that were of a high quality, and then that they wouldn't be harmed in any way financially for those. And the 4 strategic objectives are those of Sláinte care, right care. So people get person-centred care that's right for them. The right time and place is very important, and there's a lot of a move and push towards early palliative care. And preparing for this talk, this comes into some of the recommendations around rehabilitation in palliative care also. And people need to be able to get care for them where they are rather than having to travel. We speak about patients having to come to us for care, or us going to patients where they are to provide the care, and both needs to be provided. I think the right people bit is very important, and from a rehabilitative palliative care point of view, the right people, a lot of you, are in this room. I think we need to have a workforce that is numerically sufficient to deliver the services we wish to deliver, and that has the training in terms of competencies and the support to do that. And we need to look at that, and I'll speak to it in a minute, from people at an undergraduate level as well as those of us who are older and longer in the tooth. I suppose what Karen Ryan and colleagues added was governed well. So we need to have clinical, operational governance. We need to have evidence that what we're doing is working. We need to develop data sets that are relevant. We need to develop, as we are, the specialist palliative care component of the Community Connect programme, which I think is going to set us in good stead ahead of the development at some stage, possibly before I retire, of the National Electronic Healthcare Record for the whole country. So I'm not going to take you through Karen Ryan's policy house, but we'll just stay with the attic, the roof and the attic. So the goal is the delivery of universal palliative care. And within the policy, the recommendations and activities are divided across the strategic objectives I mentioned earlier on. There are 25 recommendations, but they have given birth to 104 activities. And Mars Dillon and Martina and Helen are working with the Centre for Effective Services to help inform the Department of Health, and Rory Egan is here and very welcome, as to the implementation plan of the 25-26 deliverables that will seek to start the work of those activities. And so one of the advantages, some people will know, of the policy being so late in being launched, was that we had achieved some of the activities before we even started, which is great. Recommendation 1.1 mentions health and social care professionals. I think that's really important. The clinical program at the minute has myself 0.5 and Martine O'Reilly in 0.7, and it's an ongoing process to try and get a nursing lead, but also to get a health and social care professional lead. And hopefully in the next short months we'll have news on that in a positive light. But just to say that whole-time equivalents are rarer than hen's teeth, and actually funding is far easier to come by. So it is an absolute priority, and some of the deliverables and recommendations in activities rather than deliverables in the policy require a person in the health and social care professional role, or persons perhaps, if the role is to be split, in order to progress them. 1.2, which is the second activity in the policy, is to develop and scale models of rehabilitative palliative care provision. So that's over to you folks. So in terms of recommendation 14, it's about developing the teams. 14.2 talks about developing the palliative care competence framework. That's for all disciplines working in specialist palliative care, in general palliative care, and to deliver the palliative care approach wherever you work in the health system. And 14.6 particularly looks at workforce planning for health and social care professionals. I mean, we have it relatively well developed through the National Doctors Training Programme for doctors. We need a nurse lead to come on board to start doing the same based on the safe staffing framework for nursing staff. But health and social care professionals who cover a broad range of disciplines also need the same support and the same development of their roles and the expansion of their numbers. And in terms of the education bit, this is busy enough, and probably can see it on the screen bigger. Definitely should have brought my glasses. This is about the education bit that actually enhances, lifts, starts, inspires maybe each of us in all of our disciplines to come towards palliative care as a career. We need to look at the undergraduate education across the universities that we have. And I think we then need to look at the palliative care education that our services are providing under recommendation 16. And an important part of the work, and I think some of the posters here will give evidence to this, but I think it's really important that we start developing a significant research and innovation infrastructure across the disciplines providing specialist palliative care. And I encourage you as a group particularly to shove yourselves to the front of the queue in that, and to be inspired by Rebecca Tabrini and others who are here with us today. So, this isn't the first rehabilitative palliative care rodeo. This goes back to work between St Francis Hospice, the Mater, Trinity and the All Ireland Institute in 2021, around the time of World Hospice and Palliative Care Day. And Sláintecare supported this project just to explore innovative models of rehabilitative palliative care. And I suppose, having visited St Francis Hospice not long ago and looking at some of the posters, if you have time to look at them, I'd recommend it. Some of those innovations are in place in the outpatient day services model run by St Francis Hospice, Dublin. Zoe Harding and colleagues in the UK basically took on a study which basically concluded that hospice-based palliative care professionals would be receptive. So this was 2022. I'm hoping that 2025, 26 and beyond means that there'll be a little less reluctance than would be receptive. This is something that we just absolutely need to do. It probably is fair to say on both sides, both the health and social care professionals on one hand and the other professions, if you like, sometimes a lack of clarity about roles. And I think we just need to have more shared roles, less siloed thinking, less siloed practice, and in simple Cork terms, just a lot more cop-on as to how we do these working. And then at an organisational level, I'm very keen from a clinical programme point of view that we harness the innovations that are happening in different centres, and that's why we've been visiting different centres and talking to people in different centres to try and pull everything in together. And the last part of the recommendation is that additional training might be required to remove blinkers and reduce blind spots of other members of the team. That's not quite what they said, but that's my interpretation of it. So, as recently as April, Manson and colleagues published another study. So they've got 5 key aspects, and I won't read them all out to you, but early referral fits with what we need to do in specialist palliative care, and you could argue in any type of care. A layered model makes sense. So based on the level of service, basing the level of service that you provide on the person's needs. Again, that's something that I mentioned at the start of the talk. A holistic assessment. I think we just need to have the broadest view of everyone we meet and be aware of across the needs, the range of palliative care needs that we're not missing, focusing on physical, focusing on psychological only. We need to look at the whole of the person. And then, I suppose, almost I think reiterating number 2 is then personalised interventions to the individual or group people of particular needs or particular levels of ability or particular goals of care into the same, let's just say, treatment session or weekly session as they do in SFH Blanchard or Raheny and Blanchardstown. Clearly, speaking back to the policy, the services need to be accessible and they need to be flexible. Again, that element of, for people who are well and ambulant and are going on holidays next week or are still having chemotherapy, they need to come to us. I think for people who are more frail, less able, more remote, less supported by family or primary care or community care, maybe we need to go to them. But we really need to look at the efficiency and the effectiveness of that. We are a finite service. I think sometimes some services hang on to people with non-specialist palliative care needs longer than we should do. And I think, again, as I suppose the health regions evolve, hopefully some of that clarity about whose role. So we're not duplicating roles at least, and then we can make sure the patients don't drop between 2 stools. And then we need to inform and educate patients and carers, absolutely, but also I think it would add to that other disciplines. And I think particularly people working outside of the specialist palliative care setting. I was speaking to a colleague about the work from Hospice UK about bringing rehabilitation to nursing homes, and Andrew and I were saying that, I mean, we can deliver some training in these settings, but because staff there are so short term, often there's a lot of staff turnover, and unfortunately I was able to let them know about what's in the media currently about some of the care in nursing homes in Ireland leaves a lot to be desired. So they concluded that integrating, good word, aspects of physio and occupational therapy, 3 good words, into community palliative care rehabilitation, I added care there as well, could help ensure that palliative care, forgot the care there, receive the therapies and the care that they need. I don't think anyone in this room is going to argue with that as an aim. Now, Rebecca, I did say I'd have your slide in here, so I threatened that Rebecca wouldn't need her first 4 slides, but that won't be the case. But for me to see that there's an AIIHPC task force that's been in place for some time, headed up by really important colleagues delivering very important work, looking to increase awareness and understanding of what rehabilitative palliative care is about is really, really important. And one of the things that I think Rebecca and your group are looking to do is, where are the barriers, where are the difficulties, and how do we work around them and improve them? And a shout out to my colleagues on the National Clinical Programme. Lauren's going to be speaking a bit later on, so I'm not going to steal any thunder, but just to congratulate them on their recent publication in BMJ Supported and Palliative Care. So, this lady wasn't a physiotherapist or an occupational therapist, but she was a genius mathematician and a groundbreaking computer scientist, but she also became a rear admiral in the Navy in the States. And a bit like in his two-skirt, I forgot to say he was on Farmar of the Dead Man. This slide is probably going to stay in a lot of my presentations. So I really believe that in anything we do, whether it's at home or at work, the most dangerous phrase in any language is, we've always done it this way. And I think it's very important that we challenge the status quo, that we don't accept that things have been grand for a long time, so we'll keep going. So, Edward Deming, massive man around change, innovation, 2 basic rules of life. It used to be death and taxes, I suppose, but no, change is inevitable and everybody resists change, even cavemen with square wheels. So, resistance to change, there are 3 types of resistance. Level 3, I don't like you, or you don't like me. Level 2 is, I don't like it, I don't like the change. And level 1, which is the main thing, is around cognition, not understanding the change. And I think I'm learning all the time that people's understanding of things is important in terms of them moving forward. So, I'd encourage you as a group, basically the community, pulling people together, working together makes a change, makes a difference. I encourage you to overcome any of the resistances that you find. I'm very keen that the clinical programme would support the development of rehabilitative palliative care, and not only because it's set out in the national policy. Thank you for your time.